All right. We will go ahead and get started. It's now 6:01. We'll wait for other people to start trickling in, but we can just go ahead and get started. I'm very, very pleased to have Dr. Larry Lowe with us today. He's one of my partners at Northwell. He is going to be speaking about updates on the management of metastatic spine disease as well as intrinsic/primary tumors of the spine. I'm very excited to see what he has to say for us today. And without further ado, Dr. Lowe.
All right, thanks, John, for the invitation. So, like John mentioned, I'm with him at Northwell Health. I'll be giving a talk about maybe like 75% of the talk is on METs, but I think it's a little bit more relevant. And then we'll go over sort of updates in management of the primary spinal tumors, depending on sort of how the timing goes. Ooh, that didn't work. Oh, I have no disclosures. So in terms of the learning objectives for the METs portion of this talk, the goal is to kind of describe the role of separation surgery, which I think is certainly the standard of care in North America in the treatment of patients with spine METs, discuss the assessment of spinal instability, and finally integrating sort of newer treatment methods such as intraoperative radiation, thermal ablation, kyphoplasty, RT, and things like that. In terms of metastatic spine disease, so really, a lot of people develop spine METs, right? It's probably by far and away the most common sort of consult reason, right? 10% of cancer patients develop symptomatic spine METs. Over 70% of patients on postmortem studies have metastatic spine disease. And part of the reason why is that we've obviously improved detection of these with better scanning methods, PET scans, but also systemic treatment has improved, which I'll talk about a little bit later. And for the most part, the biologics and the immunotherapy, the molecular targeted therapy, at least anecdotally, seem to be a little bit better at visceral disease than bone disease. So oftentimes as spine surgeons, we end up seeing a lot of these. And really the goals of the treatment are neurologic palliative, right? Neurological function, tumor control, mechanical stability, pain relief, and improved quality of life. So then I think Dr. Bilski and Mark Bilski and Ilya Lauf talk about this a lot, but I think it is true. I do believe that the single greatest advent in the management of spine METs has been stereotactic radiosurgery. It allows us to kind of deliver a high dose of radiation to the vertebral body, to the tumor. It's much shorter treatment time or treatment sessions compared to conventional fractionated radiation therapy. You're able to deliver cytotoxic tumor doses. And by now we have sort of a vast experience of sort of how to come up with a contouring, as well as understanding the tumor cytodoses with dose constraints for the organs at risk, as well as the radiobiology of SRS. So within this sort of paradigm, Ilya and Mark came up with this sort of NOMS decision framework, primarily from Emerson Kettering, where the four pillars are: what is the neurologic status of the patient? What is the oncologic status of the patient? Is there any mechanical instability? And finally, what is the systemic disease status? And that really, depending on all four of these factors, we offer the patient some combination of systemic therapy, radiation therapy, or surgery. So from a neurological perspective, I think it's pretty straightforward as neurosurgeons or spine surgeons see this all the time, where essentially does the patient have myelopathy, symptoms of spinal cord compression? Does the patient have radiculopathy, nerve irritation from the tumor? And what is the extent of the disease in terms of the spinal canal portions? And Dr. Bilski coined this term of the epidural spinal cord compression scale, where basically anything from 0 to 1C is some combination of the tumor touching the dura, but not necessarily actually deforming the spinal cord. Grade 2 is when it actually starts deforming the spinal cord. And then grade 3 is when basically there's complete loss of CSF. And grade 2 and grade 3 are considered high grades in terms of this Bilski ESCC scale. So from the oncologic perspective, I think sort of the traditional thinking was that what is the radiosensitivity of the tumor? And depending on that, we either deliver a conventional external beam radiation, SRS, or brachytherapy. It turns out that there's actually quite a bit of variation as to sort of agreement on what's considered radio-resistant or radiosensitive, but this Peter Gertzen paper back in 2009 kind of summarized a lot of the more recent studies. And I think we can all agree that your myelomas or seminomas or lymphomas or breast cancers or prostate cancers are generally considered radiosensitive. while your sarcomas, your melanomas, your renals, your lung cancers, your GI type tumors, these are considered radioresistant. And if you look at the mean response duration for these two different groups, the reason why we categorize these is because the median response duration for radiosensitive tumors are quite good. 11 months, 2-year local control rate is well in excess of 86%. Whereas for the radioresistant group, we only control the tumor for about 3 months after radiation with conventional external beam. And essentially we have more failures than not at 2-year mark with only 30% local control rate. So the reason why sort of SRS is a game changer is that it almost makes the radiosensitivity of the tumor irrelevant. Essentially, everything's radiosensitive as long as we can deliver enough dose. And the full 2-year local control rates are basically 98%. And this comes from the seminal paper that was published from Memorial Sloan Kettering with Dr. Yamada being the lead author on this, where they looked at 811 lesions in 657 patients, and 82% of these patients had radiation therapy considered resistant histology. And if you look at this total group, the overall control rates were quite good. Basically at 48 months, they only had a 3.1% failure rate. But if you stratified that by low dose versus high dose in terms of 16.4 grays versus 22.4 grays, you saw that the high dose group had essentially 98% local control rate, whereas the low dose group basically only had 80% control rate at 48 months. So really the dose really does matter. And the reason why we consider this to be a game changer is even back when I was training, something like this where it was bone-only disease, T12 solitary renal cell met, we would do en bloc operation for this, where we would have this massive operation that would have like 10-hour plus operating time, and we transfuse multiple units. Whereas now this is a quick procedure. This is a quick outpatient procedure with no blood loss, 20-minute treatment time that has essentially 90% local control at 2 years plus. So then the natural trend, that begs the question on why don't we do this for all tumors? Why don't we just stop doing surgery for these patients? And this actually has been studied by multiple groups. And essentially the SRS for high-grade spinal cord compression, for these patients, the issue is that in order to maintain the dose constraints of the spinal cord within 14 grays, essentially we end up underdosing the tumor at the dural tumor margins. And the failure rates for SRS only for high-grade ESCCs lesions are quite high. So if you look, this is a study that looked at 85 lesions in 62 patients, and they had a 20% failure at 9 months, very similar to what we're seeing in sort of conventional external beam. So really, this is the biggest reason why there is the role for surgery. So basically from a neuro-oncological assessment, if you have a radiosensitive tumor, whether it's either a low-grade or high-grade core compression, you just do conventional external beam. If you have something like a renal cell that's radioresistant, you do SRS. And finally, in the surgery arm, it's predominantly reserved for patients with high-grade core compression that have radioresistant histologies. So this is probably the single most widely cited paper in spinal oncology, but this was a prospective randomized study done by Pacho et al. From the University of Kentucky, I think, back in the 2000s, where they looked at solid tumors. They looked at patients with high-grade ESCC with myelopathy, and they compared basically surgery plus external beam versus conventional external beam alone, and they excluded RT-sensitive tumors, multi-level disease, and those patients that couldn't really survive surgery. And if you look at the study, basically surgery was superior for overall ambulation, duration of ambulatory function, narcotic usage, ability to recover ambulatory function, as well as overall survival. Essentially, it was superior in every aspect. The study was actually designed to show that there really wasn't a role for surgery, and this actually had to be terminated early because the surgery plus radiation arm did so much better. So based off of this evidence, basically a strong recommendation can be made for patients with high-grade core compression with solid tumor mets to undergo surgical decompression and stabilization followed by radiation therapy. But the question becomes, what kind of surgery and what kind of radiation are we talking about? So in terms of the surgical goals, what we're trying to do from a neurological perspective is obviously address the spinal cord spinal cord compression. But then from a mechanical perspective, we want to restore the stability. From an oncologic perspective, we basically, in the advent of conventional external beam radiation therapy, we actually were aiming for sort of like a gross total resection because our options from the radiation perspective are limited. But now in the advent of stereotactic radiosurgery, really the goal is to reconstitute the thecal sac and to basically give a good target for the radiation. And that's where this role of separation surgery comes in. So essentially, I think this gets confused quite a bit oftentimes when people sort of confuse sort of separation surgery for just a conventional laminectomy, just to kind of do an indirect decompression. But these were the steps that were outlined from the MSK group, where it's actually a bilateral pediculotomy, and you have to actually resect the posterior longitudinal ligament and truly fully reconstitute the thecal sac based off of either post-op imaging or intraoperative ultrasound to really fully, completely debulk the spinal canal. And this is the typical thing we're aiming for, where basically this is a T2 MRI pre-decompression. We can see that the spinal cord is basically completely obliterated by the tumor, and post-operatively, you see that the fecal sac has been reconstituted. So it's not just a laminectomy with an indirect decompression, which at least I've heard sort of from different talks or from talking to some colleagues. So if you look at the outcomes of surgery with conventional external beam, this is sort of old data from 1998, where essentially the local control rate at 1 year, as we predicted, is quite poor, 30%. And if you looked at the predictors of failure, the tumor histology was one. If you compare that to a more modern cohort from Memorial Sloan Kettering looking at separation surgery followed by SRS, you see that essentially they had 186 patients, 70% of these patients had high-grade core compression, close to 80% had radio-resistant histology, and half the patients have already failed prior radiation. And they had sort of numerous SRS strategies in terms of the fractionation schemes, but overall, that had a 16.4% one-yearly recurrence, but in the patients that got the high-dose hyperfractionated scheme, they actually had an excellent one-year local control at 96%. And the key thing was that there was really no association with tumor histology, previous radiation, or even epidural extension, because theoretically surgery took care of the epidural disease. So this is sort of what we base sort of model more modern treatments of spine mets off of, this type of data. And obviously from a surgical perspective, these are very different operations, right? So typically for separation surgery, it's a much shorter operating time. It lends itself to emergency operations because essentially the technique is somewhat familiar in terms of doing a laminectomy, potentially at a normal level, and then tracing the normal dural planes down to the tumor level and coming circumferentially to debulk the cord. Debulk the tumor. And basically, this lends itself to sort of these large multi-compartmental tumors.
Oh my God. Yeah, sudden transient unexplained quadriplegia.
Anyway, so the only area we're targeting is sort of this epidural disease portion, rather than this entire tumor that's basically extending into the retroperitoneal cavity. And this allows for essentially a posterior-only decompression without the need of a lateral and anterior stage with an access surgeon. So then sort of newer things that we're doing without that avoids the need for sort of traditional open operation. This is a technique that was described at MD Anderson by Claudia Tatsui, where they're doing spinal laser interstitial thermotherapy, where essentially patients, fiducials are being placed on the patient gets scanned in the coil, and then they register the marker similar to using the BrainLab platform. And what they do is, based off this radiation, they introduce a laser catheter with either a transpedicular approach shown in the blue or translaminar approach in the purple, or sort of a straighted approach vertically. And basically the catheter is introduced into the target area for ablation. And what ends up happening is that with live MRI thermography, they're getting live feedback in terms of the actual ablation of the tumor in order to debulk the epidural disease. And this is a really slick technique where essentially you're able to actually get the separation without actually an open operation. And this is a case that they showed where this was a left C1 lateral mass lesion that was causing sort of oncologic pain, but there was no mechanical instability. You can see that from a traditional open operation, this is a bear to get to, right? You've got the carotids in the front, you've got the there. Whereas with a stereotactic navigation technique, introducing the lit catheter into there, you can see that you can deliver ablation to the tumor to kill the tumor. And you see that essentially there's no contrast enhancement in that area that was previously enhancing, showing that essentially you've successfully ablated that lesion without a traditional open operation. So obviously there are limitations to this technique. I think the biggest limitation is that essentially you're only protecting the spinal cord, you're not really protecting the nerve roots. So then in an area where there is a functional nerve root, such as L2, L3, L4, things like that, essentially what can end up happening is it can cause a nerve root injury. So it's currently limited to the thoracic spine, or sort of areas where the nerve root injury is not an issue, such as C2 or C1. So then from a mechanical stability perspective within the NOMS framework, I think the biggest thing is understanding sort of whether there's instability or not. And I think we'll talk about the SIN score right away, but basically having that sort of common language for us to all go to has been quite helpful. So in terms of treatment options, we can either do a kyphoplasty, we can do a percutaneous screw fixation, we can do open surgery. And basically, I think what the SINS score did was that it just kind of put everything in writing in terms of all the different factors that we consider in terms of addressing instability. So obviously location, if you're in a junctional area, that tends to be subject to a lot of movement, that tends to get a high points. If the patient's already having pre-existing mechanical pain, that tends to give you higher points as well. And obviously if the tumor itself is breaking the bone down and lytic, that gives you sort of a higher potential for instability. If you see on x-rays or a CT scan that there's already a subluxation or translation or some type of deformity, that gets assigned points as well. And if there's basically the more vertebral body element in the anterior column, especially with collapse, that gets assigned points. And finally, if you have posterior element involvement, that gets assigned sort of higher points as well. And putting that all together, you get this sort of grading scheme where essentially everybody can agree that 0 to 6 is more or less stable, 13 to 18 is unstable, but you have this middle zone where there's clinical equipoise, and you take it by a case-by-case basis. And if you look at sort of how this scheme does in terms of inter and intra-observer reliability, then the coefficients are quite good, and it's really pretty sensitive, 96% sensitive and 80% specific for having instability.
Larry, do you mind if I just interrupt for a question? Sure. Very quickly? This is actually something that Wendy and I have talked about, and I'm just curious your thoughts about it. What do you think would be the utility of, sometimes the first time we hear of a patient is when they come into the emergency room and they, let's say with acute paraplegia, they get a MRI, and then, we see the MRI scan, we take a look at it. How useful do you think it would be for the radiologist report to include these grading scales, like the epidural metastatic spinal compression?
I think that
NOMS.
Absolutely. I think that like having, I really, like from a radiology report perspective, I really like the sort of like the normalized reporting format where like at the T12L1 interspace, how's the canal? How are the nerves? Is there bony involvement? And then if there's an end report of like at ESCC is grade 2 and the SINs, well, they can't really predict the SINs, right? Because that's also, there's a part of a clinical nomenclature to that. Right. But at least if they can comment on like the posterior element is involved and the vertebral body height is 50% collapsed or whatnot, I think that would be helpful. Like I really do appreciate, I feel like there's a lot of variability in the radiology reports. And I personally like the sort of like the normalized reporting scheme that in patients with spine mets or spine tumors, I think that having that sort of presentation of the vertebral body involvement, posterior element involvement, spinal canal involvement is super helpful.
Sounds great. Wendy, how on your side of things, how difficult or easy has it been to get standardization in terms of having radiologists report those scores? I'm just kind of curious.
Yeah, thanks. So I started talking about this at our national meetings about 4 years ago about this very topic, SINs and ESCC. And at that time, nobody had ever even heard of it. Now, I think there's a big movement. All of the newer radiologists are really on board with doing this kind of reporting, and there's a lot of excitement about it. And we're still talking about it at the national meetings, still bringing this up, and it's still a great way to teach people about standardized ways of reporting using the surgeons, the information from your literature, basically, that you need to know, and in a way you need to know it. So it's a battle, I think. A lot of people just are still, people like to report the way they do. But the newer people who are just starting out learning are much more amenable to doing this. So we're trying and hearing things like this, that you all like it, that's really helpful, supportive evidence.
Yeah, absolutely. I mean, back at where I was previously, we demoed the standardized reporting scheme with the SINs, as well as the radiographic elements of the SIN score, for a month. And it was now we couldn't get buy-in from all the radiologists, but at least from a clinician, from a surgeon perspective, we all loved it. I think that it was amazing.
And if I ask one more question, Larry, if you go back one slide just to the components of the SIN score. And then this is kind of open to all of our panelists. If you had to pick, let's say, assuming that we take the neurologic exam out, in your opinion, which one do you place the most weight on of all of these? If you had to pick one, that would be just pick your.
I can tell you my answer. I think the point value reflects that. I think that it's a no-brainer if the patient's subluxed or there's something dislocated or dislocated or whatnot. So I do think that at least from an instability perspective, that's not even a spinal oncology thing, right? You see somebody with bilateral jump facets or subluxed spine, I think obviously we think there's instability. I mean, that's for me.
Yeah, agree. Mike Galgano, Mike Selby, any comments?
I really like the SINs, but it's just not widely used here in Australia enough. And think, this is a sort of talk I'm going to send Larry's talk to my radiation oncology and oncology colleagues, because this stuff needs to be better known. So, yeah.
And one of the, this kind of cuts to the later parts of it. But as you mentioned, I was surprised that I was just recently overseas at a conference, and I was surprised that this type of thinking is actually, there's a wide variety of geographic variations as to this type of hybrid surgery strategy is adapted or not. And there's a lot of variability on the surgeon side on whether they still do en blocs for bone-only disease. And from a radiation perspective, there's a lot of sort of inconsistencies as to the dosing scheme, as well as what's considered an acceptable core tolerance. So I agree that I think that at least in the US, I feel like it's a little bit more widely permeated, but certainly that is not the case around sort of our international colleagues. But anyway, sort of continuing along. So obviously for the stability perspective, I think everybody knows what a kyphoplasty is, so I won't harp on this. It's just a percutaneous technique for sort of an anterior middle column reconstruction. What's slick is that you can also sort of deliver radiation through the kypho, at the same time as the kyphoplasty. This was a technique that was initially described in, I believe, Germany, that we've adopted here, where basically at the time of kyphoplasty, the radiation catheter is introduced here, and basically the prescription dose is 10 grays prescribed to the minimal distance to the nearest organ at risk, which ends up usually being the spinal canal. And then right after you deliver that radiation, you do the kyphoplasty. And the local control rates are actually pretty favorable. If you look at the control rates, so this is a study from Germany where they looked at sort of 143 lesions. Essentially, their 1 year local control rate was 97%. And at 2 years, it was 96%. So it's pretty comparable to sort of your more traditional separation surgery with SBRT techniques. So it's just something to consider if you're doing a lot of kyphoplasties. I think that this is something that we've adapted here. Obviously, from a surgery perspective, we always try to make the surgery less invasive. And obviously, we can do sort of a percutaneous pedicle screw fixation, or a hybrid strategy where the implants are placed percutaneously, but you do sort of a mini open incision in the middle to debulk the epidural disease. And I think this is a case. This is a case where something like this is perfect, where this patient has really widely metastatic renal cell cancer, and essentially the expected prognosis for this patient, told by the oncologist, was like well under 6 months. And if we were to address this with a sort of an open technique with a laminectomy and whatnot, this would end up being some sort of thoracolumbar fusion, because you can't really get good fixation points at those points above, and there's disease down below as well. So rather than subjecting the patient to something like this, where this L3 radiculopathy was causing the patient to be non-ambulatory, we can do sort of an aggressive preoperative embolization and then just do sort of a mini corpectomy through a tube to basically remove a lot of that disease and sort of reconstitute the fecal sac. And you can see that even with sort of a tubular, you can see exactly the track that we took, but you're still able to debulk a fair bit of the tumor and address the patient's radiculopathy as well as a caudate guina compression. And this patient left the hospital post-embo day 2, post-op day 1, and basically died 8 months later, but at least was ambulatory for that portion. So I do think that we kind of accomplished our goals. And finally, the more traditional open surgery where we have to open everything up. I think that the intraoperative ultrasound is key to kind of make sure that the fecal sac is reconstituted. So that's what we sort of default to in a lot of cases. I think one of the things that has fallen away because the company has, the company that makes this P32 plaque is actually bankrupt, or they're not making this anymore. So we're currently kind of in a bit of a lull right now. But when we had this was great where you could actually apply intraoperative brachytherapy through this film that's applied to the dorsal aspects of the spinal cord. And what was great about this was that if you look at the dose taper, right? So essentially at 5 millimeters past the film, there's no radiation being delivered. So really, you didn't need special lead-lined rooms or some type of fancy equipment with catheters. You just needed to wear lead gloves and handle this and place this on the dura for basically a couple of minutes, and you would be able to deliver 1,000 grays at 1 millimeter depth. And what you could see is that if you intraoperatively cover that posterior portion from using the 32P plaque, then postoperatively you can completely ignore that area and just cover the anterior portion. So that allows us to essentially deliver higher doses without hitting the core tolerance with these donut type plants. And so unfortunately, like I said, we're in a bit of a lull right now where the company that made this has ceased to exist. So there's sort of a lot of sort of exciting new similar types of technologies that are coming down the pipeline. I think another thing that we do these days is to use kind of radiolucent spinal implants. I'll talk a little bit more about this during the primary tumor portion, but basically by using radiolucent spinal implants, we can sort of eliminate the need for a postoperative CT myelogram, and also allow for better surveillance of the tumor. So you see that we're using radiolucent spinal implants here, and essentially there's really no streak caused by the implant. So instead of using a CT myelogram for postoperative radiation planning, you just get a regular MRI, and that sort of probably cuts down the hospital length of stay by a day potentially, because I find that they usually, between planning for the myelogram, having to lay them flat after the myelogram, they usually end up staying in the hospital an extra day. So finally, the last component of the NOMS framework, the systemic portion. This is a landmark paper that was published in the New England Journal of Medicine, where essentially you can see that immunotherapy really dramatically improves survival of patients with metastatic melanoma compared to DTIC. And sort of what this is trying to get at is that essentially patients are living longer and longer. So we have to be better at predicting like essentially their survival as well as their potential complications. This is a paper that we published looking at sort of the metastatic spinal tumor frailty index, where we looked at various different factors to understand how likely they were to die, have a complication from surgery, or have a basically longer hospital length of stay. And the factors that panned out were anemia, chronic lung disease, coagulopathy, having electrolyte abnormalities, having some type of a pulmonary circulation disorder, kidney failure, malnutrition, if it was an urgent case or if it was a two-stager. So I think that a lot of this is intuitive, but then I think it's nice to kind of get it out there so that it actually makes a difference. These are the factors that we should consider before offering the patient separation surgery. And this is a great study that was done by Joe Schaub from the Skeletal Oncology Research Group back in 2017, where they basically developed this in 649 patients, and they validated this at a 100-patient data set at Memorial Sloan Kettering, where they basically had this nomogram where essentially you add these points up and understand exactly what the 30-day survival, the 90-day survival, as well as the 1-year survival of the patient. And you see that they did a very interesting sort of primary tumor classification where it was pretty much binary. So group 1 tumors were lymphoma, breast cancer, multiple myeloma, kidney cancer, essentially cancer types that we attribute to potentially having at least potentially better survival. And then basically your group 2 were basically lung cancer, colon cancer, rectal cancer, bladder cancer, esophageal cancer, things that, or melanoma, things that we would attribute to potentially poorer survival. And if you look at sort of how great, how good this is compared to older scoring scores, such as the Tomita score, Takahashi score, the Sorg normogram did great compared to those, showing that this is something that's really quite valuable in sort of us predicting whether patients will make it or not in terms of the surgical decision making. So if you put all this information together, you get this crazy looking diagram, which actually is a lot more simple than it looks. So this is a paper that was published by Ilya from MSK, an oncologist, in 2013. But if you break it down, all this is saying is basically, if the patient has low-grade spinal cord compression and a radiosensitive tumor, they should probably get radiation of some sort, but convention externally. And same thing, even if they have a high-grade cord compression, if they have something like a multiple myeloma that's within the spinal canal. Sorry, give me 1 second, just close the door. All right. So if they have, even if they have high-grade cord compression, you can still just radiate it and address the neurological issues. If they have no low-grade cord compression, but then they have a radioresistant histology, these patients should probably get SRS due to the chances of the convention externally causing local failure. And finally, if they have high-grade cord compression and radioresistant tumor, they should get separation surgery followed by radiation. Obviously, the mechanical axis of this, if they have unstable, if they can tolerate surgery, they should probably get to some type of stabilization. And obviously, the systemic factors, the systemic status in terms of prognosis is also a consideration, where obviously, if their 30-day survival probability is under 20%, it probably doesn't make sense for us to offer them surgery. So if they're unable to tolerate surgery, they should basically get radiation. So then putting all this together, I think from a historical perspective, so where we were before, where are we now? So essentially the first spinal SBRT, was discovered in 1995 at University of Arizona. Essentially the Pedicle study came out in 2005, where essentially showed that clearly surgery had a role for patients with high-grade cord compression. In 2010, the pivotal paper from Memorial Sloan Kettering from Dr. Bilski reported the first pilot study of separation surgery, or what they call now hybrid therapy. And finally, in 2015, Claudio Tatsui at MD Anderson discovered this sort of lid therapy for essentially debulking the epidural disease without open surgery. So I think where we are now is we've really swung, at least for sort of bone-only disease, for something like a renal cell cancer, from doing an en bloc resection for that to essentially either radiation only or separation surgery. So essentially, the question I think that's provocative is, have we really solved metastatic spine disease with hybrid therapy now? So if you look at sort of our institutional experience, this was this paper where Kristen Redmond's the lead author on, but essentially, our local control rates for metastatic spine disease was essentially comparable to what's been published, but it was 90% at 1 year. And if you look at sort of overall survival, a majority of those patients died within the first 10 months after surgery, but in the patients that survived, we had sort of durable local control. But I think the provocative question to ask is, what happens when the survival starts improving, which is what we're seeing now, and I'll show a little bit of additional data. Are we going to still maintain that 90%, or when the survival improves, we see local control rates? So what we looked at was sort of 97 patients undergoing surgery followed by SBRT, but stratified by the extent of anterior column resection or anterior column reconstruction. And you see that in the patients where we basically did an anterior column reconstruction, we saw at least more durable local control compared to the patients where we did basically only sort of a epidural only ventral debulking without actually getting into the vertebral body. So at least this would be potentially suggest that for the longer term survivors, that potentially there's more more utility for more aggressive resection. Although again, this could also be just simply a radiation phenomenon where by doing a more thorough resection, the radiation schemes are better. So we have to kind of answer that question. And also, as the patients live longer and longer, we're seeing more and more construct failures. Essentially, this was a study that was done in 2014 when basically they quoted a 3% failure rate from the MSK cohort, where essentially they had rod breakage or screw pullout or symptomatic vertebral body fractures. But then again, 80% of their patients died during the study period early on. So what happens when the patients are living longer and longer? We anecdotally see that for the long-term survivors from the metastatic prostate cancers or the breast cancers, that we see a lot of hardware failure without an anterior column reconstruction. So I think that we need to do better studies to see which patients are we going to be more selective and in terms of doing a sort of a more aggressive operation. This was a slide that I got off of Google from Our World in data, where you could see that from the period between 2007 to 2013, compared to the prior period of 1970 to 1977, essentially survival has improved for all cancer types, with the exception of cervical cancer. And this is a more modern study from the American Cancer Society, where you can see that obviously this spike is probably better detection, but then for cancer survival for all cancer types for male and female we've been improving the survival as well. So going back to this question of where are we now? So have we solved the metastatic disease with hybrid therapy? And I do think that there probably is a selected cohort of patients where we should be more cognizant about the reconstruction in terms of using either bone cement or potentially doing a cage in the front, or that we know that that local disease is going to be a nuisance and we should potentially aim for an intralesional gross total resection up front rather than sort of a partial separation. So I think there's multiple study groups that are out there, including the AO Spine Knowledge Tumor Forum, as well as the Spine Tumor Academy, that are looking at potentially answering this question. I think that this is unanswered as of now. It certainly could just be a radiation phenomenon, but certainly we should study this. So in terms of like the conclusion for this portion of the talk, essentially separation surgery has a limited role in patients with high-grade spinal cord compression with radio-resistant histologies. I think the spinal stabilization portion is critical. It is an independent assessment. It's just a matter of whether they can tolerate that surgery or not. And finally, in terms of, I think the key thing, as with sort of all tumors, is that really we have to take a multidisciplinary approach that includes oncologists, radiation oncologists, neuro-onc, the neurosurgeon, the orthospine surgeon, the pain medicine, everybody involved to kind of come up with the best treatment care for these patients. All right, so I'll use like the last 10 minutes to kind of briefly talk about primary spinal tumors, which is like a whole separate discussion. Or
hey Larry, real quick before you move on from Mets, you mentioned it quickly, but it's one thing I learned from you, or it's one of the many things I learned from you. But do you mind just hitting on real quickly your process in terms of getting an embolization and doing multiple levels, and talking to the IR folks about it and kind of how you go about that?
Yes, absolutely. So I think the key thing is that I think not all embolizations are equal. And what I mean by that is, let me go back to that previous case where this is a case like this, where this is a metastatic renal cell and we're working through a Medtronic quadrant tube or matrix tube or whatever. Like any type of bleeding is going to make the surgery impossible. So for something like this, where like I really do need like great hemostasis from the embolization, I will talk with the I will talk with the neurointerventional radiologist, be like, you know what, can you please at least inject like 4 or 5 segmentals above and below, just to make sure that there's not a specific contribution. And then barring like a true ASA or an Adamkowitz coming off of the segmental, I want like a complete casting of the tumor. So if you take a look at sort of the AP view, essentially it's actually a combination of coils in the areas where the posterior spinal artery was coming off, as well as basically glue to completely cast those vessels. So I think that open communication with the neurointerventional radiologist is critical, because I think there are cases where it's nice. For example, let's just say that you're doing like a multi-level laminectomy for like, I don't know, like colorectal cancer, that doesn't tend to bleed that much, but obviously it's an elective case and the patient's being embolized. I think that's fine, where like, even if they do like only like a 30 or 40% reduction, at the end of the day, it probably cut down EBL in the surgery by 400 cc's, but it wasn't critical to the success of surgery. Whereas a case like this, where like you have something that could potentially lose a leader very, very quickly, and you have very poor visualization, I think that the open communication is key. And I'll kind of push the interventional radiologists be like, you know what, this is like critical. I know that there's some risk to the spinal cord circulation, but I need you to push it a little bit. And obviously we'll tell the patient up front that because the ablation is critical, yes, we're going to push it a little bit. There's a small chance that you might suffer a spinal cord stroke, but then if we don't actually push it, then we can't even do the surgery safely. So I think it's an open dialogue with both the patient as well as the interventional radiologist.
That's so critical, because one of the things in the literature is that, you know, that after embolization, you'll see several papers out there where the blood loss is similar and it doesn't seem to matter that much.
Right.
And we've certainly experienced that. And I think that's one thing I learned from you, was really being very aggressive about those for the renal cells and the ones where you know you have potential to get into a lot of trouble. So
exactly. I think that, I mean, it's somewhat misleading, right? The tumor blushes always decrease at the levels you coiled or you put in material, right? The question is that an actual durable clinical thing? And the really only way to study that is to inject the other levels, right? But anyways, all right, so moving on to sort of spinal column tumors. So this is the exact opposite strategy where I think the surgery plays a very, very big role. So these are overall very rare tumors, right? It's only about 2.5 to 8.5 cases per 100,000 in the US. And there's no question that instead of sort of surgery being supplementary to radiation, for a majority of these cases, standard of care is a curative surgical resection coupled with adjuvant therapy. So obviously this is an old paper published in 2011 looking at a lumbar chordoma, but this is something that we do where we want to get negative margins around the tumor, come around the tumor cleanly, get some soft tissue cover if possible. But despite our best efforts, especially for chordomas, these tumors are notoriously sticky, right? So you can see that the classic recurrence is always in the muscles or close to sciatic notch. We see that despite you getting negative margins at the time of surgery, presumably due to micrometastases or tumor that exists beyond the sort of obvious capsular margins, we get a local recurrence. So we still have a lot to work to do, because despite our best efforts, we still get about 60% local control at 5 years, which is good but not great, right? So one of the things that we've looked at is the potentially doing neoadjuvant RT for chordomas. And obviously the study length on this is not quite long enough to understand whether this has a role, but at least from our experience, this is basically 28 patients with 30 discrete lesions, and a majority of these actually received radiation before surgery rather than after. And the concern for a neoadjuvant treatment paradigm was this causes wound breakdown or makes the surgery more difficult, potentially leading to more complications or whatnot. So essentially our local control rates at 2 years was 96%. But if you look at the complications in the neoadjuvant treatment arm, there was actually very minimal. There was only one postoperative complication, and this was basically actually a pleural empyema. And it's possible that was related to surgery, but I doubt that really this is something that the radiation had caused. And if you look at the wound infection rates, it was actually lower in the neoadjuvant group. So at least it seems like this is potentially promising, because delivering the radiation preoperatively, the thinking there would be that you're making the tumor as dead as possible. So theoretically, even if you have some type of spillage that you didn't recognize, it's irrelevant because a lot of the tumor is already dead. I think the radiolucent spinal implants for primaries is actually where the primary indications are, where it's critical for us to basically be able to monitor these very carefully, because especially if you're not doing adjuvant radiation, because obviously at signs of early local recurrence, we could potentially zap that with high dose proton beam or stereotactic radiosurgery. So I think radiolucent spinal implants are key for primary tumors. I think that we continue to try to innovate with the surgical techniques that we use. So this is a patient with a sacral solitary fibrous tumor, where we basically, instead of doing a massive sort of high sacrectomy, we just elected to kind of get bony margins around the tumor by coring around it instead of traditionally amputating the sacrum. And obviously the tumor anatomy was very favorable to that because the actual sacral involvement was low. And what we did was essentially core that out and essentially do a sacroplasty to reconstruct the sacral ala. And in order to help with the pelvic ring and stability, we placed S2 implants with a fibular strut going across it to kind of help reconstitute pelvic ring. And this actually ended up being a grade 3 meningothelial solitary fibrous tumor. So I think that having that pelvic ring reconstruction in place also helps with the radiation aspect as well, in case the radiation does weaken the sacrum. For selected cases like this, where this was sort of a lateralized chondrosarcoma, where it did go into the spinal canal, but not completely. And for something like this, we can actually do a relatively nerve-preserving asymmetric sacrectomy, where we basically ligated the S1 and S2 nerve roots on one side, but kept everything else intact. And we delivered the tumor along with the L5 pedicle and the posterior elements. You can see that we're still able to kind of safely get margins around this without breaching the tumor. And again, obviously this is a very favorable anatomy because the tumor was very asymmetric, but it allowed us to basically, instead of ligating the fecal sac at this level, which would obviously cause significant deficits, we were able to kind of come around this with sort of minimal sacrifice. And I think this woman's about 1.5 years out now, and she has actually reasonable foot function and can walk without using a walker or any type of AFO device. And obviously, we're cutting the margins tight in that area, but I do think that is something to consider in terms of the patient's actual quality of life after a big destructive operation like this. We also have potentially newer technologies to help guide our osteotomies. This was a case that was done by Camilo, one of Dr. Guden's partners at WashU, as well as Dan Shuba, my boss here. But basically, this was sort of an augmented reality guided pedicle cut to kind of help come around this. And it's just another way of doing the navigation, but it's a little bit more ergonomic. And again, sort of we're using sort of newer technologies and incorporating them into our tumor resections. And finally, there's still the role for sort of traditional block techniques where we just really have to widely come around the tumor. This is a patient with a suspected dedifferentiated chordoma that got a neoadjuvant chemotherapy to kill as much of the tumor as possible before surgery. And you see that this is a massive tumor that encroaches L5, part of L4. It actually touches a little bit of the sacral ala as well. And if you look at the spinal canal involvement, it really completely obliterates the spinal canal. So we actually saw this patient as a second opinion because it was deemed sort of not resectable cleanly. So the patient was offered sort of an intralesional debulking rather than a true oncologic operation. And these are the T2 images showing that really that's not an unreasonable thought given that that triangulated portion is a fecal sac, so there's almost tumor circumferentially. But for this patient, we actually got fairly fortunate because it turned out that essentially once we preserved that spinous process and made our laminar cuts in the clean area on the contralateral side, this lamina was actually a little bit mobile, so we were able to actually open up kind of the door in the spinal canal to actually do the tumor dissection and do the nerve root sacrifices. So you see that we were actually able to come around this cleanly, and even in the spinal canal portions, the margins were negative, although obviously it was right on the fecal sac. And again, we were fortunate in the sense that this portion of it rotated out. So you can see that I'm kind of holding that open, but that's how we were doing the entirety of the surgery with essentially the laminar spreader wedged against there to kind of open up access to the spinal canal. And obviously, again, this is cutting the margins tight, but then this is certainly better than ligating the fecal sac at L4 to get a true margin, which would be obviously have tremendous deficits, or intranasally going into the tumor to debulk it and spilling the tumor everywhere. And obviously this is still early, so it's hard to say, but this is the 4-month MRI after surgery, and see that at least there's no clear residual tumor. And obviously the reconstruction looks good, and there's some early bone formation across the cage, and you can see all the clips and whatnot. But again, this is a case where it was a logistical issue, but the radiolucent spinal implants were not approved at our hospital at the time of surgery. But obviously, if you imagine you had radiolucent spinal implants here, they would make the surveillance much, much easier. So in terms of the conclusions from the sort of the primary section, which is a little bit shorter, I do think that the en bloc resection still remains a mainstay of the treatment. I think that in selected cases, it can be less invasive in terms of both the motion preservation as well as the nerve sparing aspects. And finally, adjuvant and neoadjuvant treatments, including chemo, radiation, obviously plays a critical role depending on your tumor histology as the margins. So I'd like to acknowledge a lot of people. Obviously, I'm not going to go through everyone. Matt, sorry, Matt Goodwin should be out here as well. Sorry about that. I forgot. That's my bad. But anyways, I'm sure there's people I'm forgetting, but this is obviously sort of a culmination of a lot of people's work throughout sort of multiple institutions, and that makes sort of a lot of this possible. And I think that it's sort of a close-knit group that we have. We continue to collaborate with each other to try to advance the field of spinal oncology. I know it's kind of before the holidays, and I appreciate those warriors that dialed in for a pre-Christmas Eve virtual spine seminar. And again, I'd like to thank thank everybody that's been running this to give me the invitation to allow me to give this talk.
That was awesome. Thank you so much, Larry. Yeah, I agree. This is the true spine group over here, spending their pre-Christmas Eve over Zoom to watch this. So I thank everybody. Any questions from our panelists or from the audience, go ahead and type it in. If not, it's perfectly okay for us to end a little bit early.
Larry, I just want to say thanks. You're somebody who I always try to talk less and listen more when you're talking. You're such an expert, and if you've ever operated with Larry, he's equally as good in the OR. And so thanks for coming on here, especially on the 23rd. Awesome talking and great cases.
Oh no, thanks. So like I said, I mean, I remember our dinners talking about the case, and I think that I think like I said, these I think even the Mets too, but I think in terms of like the primaries, I think it truly requires like an army of people to think about sort of how to plan the cuts, what to do before surgery from a neoadjuvant perspective, what to do after surgery. And I really sort of value those discussions. I still continue to run cases by Matt and sort of by my partners around the country. So.
Larry, we've got a couple of questions on the chat box if we've got a moment. I think we've got a couple of minutes. Yeah, look, Matthew Birchuk, who's a regular contributor, has asked, what about the patient who presents with unknown history?
Unknown? I think that we try to avoid that situation as much. I'm assuming that the scenario is the patient presents with an unknown tumor with like core compression where surgery is somewhat urgent, right? I'm going to interpret the question that way. I think that obviously if the neurology is at risk, meaning that the patient's going paraplegic or suffering consequences from that, I think obviously you go to the surgery right away. And if it ends up being like a primary osteosarcoma, you just do your best to try to do an intralesional gross total. If at all possible, if this is not an urgent or emergent case, obviously we try to avoid a situation where we go in blind. So you try to do either a CT guided biopsy or whatnot to try to understand what it is. But obviously in a true urgent scenario where the patient is at imminent risk for permanent neurological damage, I think all that goes out the window and you do your best within the confines of what you're able to do. I've only had one case where we biopsied the mass so many times and it still came up as sort of an undifferentiated a sort of carcinoma of unknown primary. It was only one time. And there's actually a treatment paradigm for those. So we ended up unblocking that, but I think that's sort of a rare scenario where it's an elective case and you truly are unclear what the diagnosis is. So we erred on the side of being more aggressive for that. But for the most part, I think that unless it's an urgent scenario where the neurology at risk, you should do some type of a biopsy to ascertain the diagnosis before surgery.
Yeah. And Larry, I think that just feeds into one more question from Victoris, just asking about the role of biopsy in primary tumors.
Oh, the role of
primary tumors.
I mean, I think it's absolutely critical, right? For example, if you biopsy it, it comes back as an osteosarcoma. I mean, that's not a surgical disease, right? That's where like the chemotherapy is probably doing the majority of the work. You're still coming around the tumor cleanly, but then the patient's getting like multiple cycles of chemotherapy before surgery, right? So I think that for primary tumor especially, it's critical because, for example, there was I don't have the images available for me right now, but there was a patient with what looked like a sacral chordoma. It was in the canal, in the bone, and it was T2 bright. It had that kind of like the bubbly appearance that looked like a chordoma. We biopsied it and we sent it for second image. It ended up being a schwannoma. And these are very different operations, right? For a chordoma, we're basically trying to either take it out en bloc or doing definitive radiation, and that probably kills all the patient's sacral nerve function. Whereas for a schwannoma, we can potentially just watch it, right? This is a benign tumor. So I think that having that information before surgery is critical. Like I said, at all possible, we do try to avoid a situation where we're going in blind. And I think the only time it's potentially justified is if essentially you're saving the patient's neurological function.
Larry, just another real quick question. Sorry, that's awesome. I've used a fair bit of carbon fiber implants. I'm still not convinced they're as strong as our usual titanium implants. And so often I use like carbon fiber around the tumor and then titanium above and below. I don't know, what's your experience been with the carbon fibers?
Okay, I mean, I might get a lot of slack from like the engineers, but I agree with you. I feel like the bone screw interface for a carbon fiber screw is it just doesn't feel quite right. Now, it just could be that it just feels different compared to a titanium screw. So what I do is when I use a carbon fiber screw, because I'm really concerned about the bone screw interface, nearly 100% of the time I'm injecting bone cement to basically to strengthen that bone screw interface. I think one of the common things that we get is that I'm sure there's engineers that could explain this better, but because of the way those fibers are aligned, I think once the screw is properly in, it's actually really strong, but like it's not very good with shearing forces. So I think that if you twist your hand funny when you're placing in the screw, or you're placing it in the area where there's a lot of rotational forces, I think that's when it breaks, or we could break it upon insertion. So I think that obviously we should get an expert on this to actually explain this, but I do agree with you that it doesn't, at least that bone screw interface when the screw is going in, it just doesn't feel quite as good as a standard Thai alloy screw. And that's why like nearly 100% of the time, I just feel like that it doesn't feel quite right. So I always fenestrate, I always cement it basically.
Agree, Larry. I use cement on all of them as well.
All right. Any more questions? Okay, so I think that wraps up the last virtual global spine for the year. I hope everyone has a very, very happy holiday and New Year, and we will be back up and running not next week, but the week after. So the first week of January, we'll have our session, and I hope to see you all there. So take care, be safe, and have a great night, everybody.
All right, thank you, everyone.